want to turn the microphone over to Dr. David Cook, who, as you all know, has, I think it's been at least 2 years, took on the role as Vice Chair for Faculty Development and Wellness here in the department, and has really grown that division and that activity for the department. And it's part of that has been developing what we call the Succeed program. And I want to turn the microphone over to you, Dr. Cook, to describe this a bit, and our distinguished visiting professor.
Well, thank you, Dr. Farmer. So it's my pleasure to introduce a great friend of mine, Dr. Leah Backhus, from Stanford University. This is part of our AATS Foundation Gardner lectureship, sponsored by the AATS. Dr. Backhus trained in general surgery at the University of Southern California and cardiothoracic surgery at the University at USC as well. She practiced at Stanford Hospital and is the chief of thoracic surgery at the VA Palo Alto. Her surgical practice consists of general thoracic surgery, and she is a very established and productive health services researcher. She has a VA Merit Award and is a co-PI on an R01 translational study examining diaphragm dysfunction amongst esophagectomy patients. She is a member of the board of directors of the Society of Thoracic Surgeons, and she is the current chair of the ACGME. So this is, she has assured me this is not a stealth site visit, and so this is definitely a visiting professorship. And she's going to discuss today challenges in post-treatment surveillance for early-stage lung cancer. Again, we would like to thank the American Association for Thoracic Surgery for honoring us with this Timothy J. Gardner lectureship. There are 2 AATS Gardner lectures this year, Dr. Yolanda Colson and Dr. Leah Backhus. And without further ado, Dr. Backhus.
So thank you so much for this opportunity. Thank you, David. Thank you, Dr. Farmer, for the invitation to come here and spend some time with you all this morning. It's actually especially poignant given that this is my first time venturing out. And it's really nice that it's not very far, which is great. You can just get in your car. Don't have to get on planes or anything like that. But this was like a while in the making because it was sort of pushed out, because of COVID. So it's been long anticipated, and it's really a pleasure to be here. I'll give a very brief shout out to my very good friend, Dr. Waite, who's in the audience as well in her non-surgeon capacity as a sports medicine doc here to come support me as I supported her during her grand rounds back at Stanford, and we went to undergrad together. So it's actually poignant for a number of reasons. So I'm going to talk about challenges in postoperative surveillance for patients with early-stage lung cancer, but really there are lots of analogies here, and you can sort of fill in the blank with other cancer types and other diseases and still try to glean some important lessons, I think, from here, and perhaps take some of the questions into those areas of inquiry. This is the, put it on presentation mode. There we go. This is the landscape in terms of the stage of distribution for patients presenting with lung cancer, at least prior to 2011. So in 2011, we had this landmark study, but prior to that, you can see that the majority of patients were actually going to be presenting with late-stage disease, which is bad news if you're involved with treating early-stage patients via surgical resection. But in 2011, we had the National Lung Cancer Screening Trial, which was a landmark study for us in the field of thoracic surgery, huge study, prospective, where actually we finally could create a linkage between early detection of lung cancer and reduction in lung cancer-specific mortality, which was really important. This was followed very closely by the Nelson study, also a very large prospective study, which again validated the findings from the NLST. And you can see the stage of distribution here in both of those studies is heavily weighted towards early stage disease, which is, of course, what the whole point of a screening program is to try to detect early stage disease to improve our opportunities for intervention and impacting their outcomes. So as a young thoracic surgeon 10 years ago, This is what I was sort of thinking about. You finally get the chance to catch your breath after having trained for so long and be a little bit reflective and think about what are the questions that you think are most important to you and that you want to pursue. So I thought about sort of this overall arch of the continuum of care for a patient with lung cancer, going all the way from screening, having a screen-detected nodule, being able to talk about them at tumor board, having the opportunity to take them to the operating room for resection, followed by seeing them in post-operative clinic and congratulating ourselves for such a great job that they've done well with surgery. And then I kind of felt like a little bit at a loss, both the patient and myself, wondering, now what? It's great, you had your cancer excised, but the now what thing really kind of plagued me. So you go to the literature to try to see what is it that we're supposed to be doing for these patients. And we should be doing post-operative surveillance. At least that's what the guidelines would recommend that we do. But my question was, to what end? Like, what are we really doing or trying to do when we enroll someone in some sort of a surveillance program? Well, I think that the benefits of doing so are laudable. We want to try to improve their cancer-specific survival. We want to try to improve their overall survival. Because if you think about it, if you're doing surveillance, you're going to find all sorts of things, not just recurrent lung cancer. We want to try to affect the system in a positive way by reducing costs and reducing unnecessary testing and procedures. And ultimately, even for those patients who recur, who have incurable disease, we want to be able to provide some palliative care and improve their quality of life overall. So if you back up further, in order to kind of see where are the opportunities for doing surveillance, you have to look at the epidemiology of lung cancer. And this is what that looks like. I thought this is a nice graph because it shows both the peaks and the incidence of recurrences for lung cancer as well as that for second primary lung cancer. And the risks are not negligible. The risk of recurrence is estimated around 2 to 3% per patient year, and the risk of a second primary lung cancer is on the order of anywhere from 1 to actually 8% in some studies per patient year. And that risk is cumulative, and that's the red line that you see down below. And this distinction is really important, I think, because it's part of the issue why we don't have as much clarity as we could with regards to the literature, because often you see recurrence and second primary lung cancer both lumped together in terms of how it is that we measure the outcomes and the successes of any particular intervention. And my contention is that they're two very different things. And in fact, we're probably going to get the biggest bang for our buck when it comes to detecting those second primary lung cancers rather than recurrences. So what's in our toolkit to try to identify these recurrences or second primary tumors? Well, you've got sputum cytology, which is sort of a bit old school at this point, but nonetheless, it's still talked about by some. But there's no proven benefit to cytology, and if anything, the data that are in existence really are extrapolated from screening programs, and even that is tenuous at best. You've got bronchoscopy, which is certainly very specific, but again, no proven benefit and significant procedural costs and risks for the patient as well as to the system. You've got advanced imaging modalities like PET scans or other provocative testing, and again, very specific, but no proven benefit. And specifically per PET scan, we kind of feel like PETs are everywhere, but they're not. They're not ubiquitously available for all patients, and certainly there's a significant price tag associated with them in some settings. You also have self-report, and I think it's important to put that on here because at the end of the day, we bring patients in to come see us, well, at least we used to, now we see them on video, to assess them via, a clinic visit. And if a patient comes in complaining of new bone pain, well, that's a metastasis until proven otherwise. So there's some benefit there, but again, it's not really proven in terms of being an effective surveillance measure. And certainly there's no standardized way within which to solicit or elicit these symptoms from patients to compare one study to the next. So this is the NCCN guidelines in 2016, and I put this up here because these are the guidelines that were in place for most of the studies that I'm going to be commenting on. And also after this was a big shift that I'll also talk about here. But you can see the NCCN had kind of a one-size-fits-all recipe here for surveillance, and that was just all comers, all treatments, get your definitive therapy, and then come back for a history and physical, as well as a CT scan to be done every 6 or 12 months. And that was for everyone. And if you look at the data, I mean, the NCCN are really smart people who are all gathered around the table coming up with these really important consensus statements. But at the end of the day, they're just trying to glean the best information they can from the existing literature. And this is the literature as it exists in and around that time. And it's pretty sparse. You can see it's mostly retrospective in nature rather than prospective. There's small single institutional series. There's no consistency with regards to the comparison arm, CT versus no CT versus chest x-ray versus no surveillance. And not surprisingly, they all comment that you can detect recurrences, so that's not really earth-shattering, because if you look more, you're going to find more things. But this is the level of evidence that we had upon which those guidelines are based. And I think that that also speaks to the heterogeneity from the other governing bodies, if you will, that we look to towards guidance in terms of how it is that we should treat patients in this space. You've got the American College of Radiology, American College of Chest Physicians, ESMO, NCCN, and ASCO, all saying various different things in terms of how it is that patients should actually undergo surveillance after treatment. And so that's a big problem. So my first question was, how are we doing? Are we even doing the bare minimum, the basics that we say that we're supposed to be doing? And so to answer that question, we designed a study, my colleagues and I at the University of Washington, where we use serum Medicare data, which most people do for a study such as this. And we looked at patients counting T0 as their time of surgery. These are all surgically resected patients. After their postoperative visit, they're supposed to be getting CT scans done every 6 months. And we honed in on that first 6 months because one of the big shortcomings of using large administrative databases when it comes to doing surveillance work is your inability to figure out what was the indication for a given test. So we could kind of try to make the assumption, if you will, that the initial CT scan done in this 4 to 8 month window, trying to liberalize it a little bit, was done for the purposes of surveillance, but we really couldn't say a whole lot about any of the other scanning that was going on. We could say that it was happening or not happening, but not necessarily why. But we looked at that first time interval, and what we found was pretty disturbing in that the vast majority of patients, 60%, were getting chest x-ray as their initial surveillance image in that first period. And only 25% were actually receiving a CT scan as their initial surveillance image. You could liberalize it a little bit by saying, okay, well, maybe they had a chest x-ray and then they got a CT scan. And even when you did that, you could only bring it up to less than half of patients that were actually receiving guideline concordant care for the first interval after their initial treatment. And then we looked to see what were some of the predictors of receipt of guideline recommended care, and we found that patients who have stage 1 disease and who had surgery as their sole therapy were at the greatest risk of not receiving guideline concordant care. And that's a big problem if you're a thoracic surgeon, because this is in fact the people who by and large populate your clinic, patients who are excited because they only have stage 1 disease and you were able to operate on them. But the reality is they're not really following up with their surgeons, and when they do see their surgeons, they're not actually getting guideline concordant care. This is another study. They also used serum Medicare, but it was nicely done. They had slightly different definitions and tried to figure out what was going on for the first 24 months. I do have some issues with some of their methodology, but the bottom line is they too found an overall adherence rate of only 61%. So still a lot of patients who are otherwise eligible, I should put that caveat there, eligible for surveillance that are actually receiving it. So this is my question. Of course, this slide is certainly dated at this point, but I think it drives the point home because my question was, well, who's supposed to be minding the shop? Whose job is it to do the surveillance in these patients? And my contention is that if you're a surgeon, you're very much concerned with filling your clinic with preoperative patients that are going to need surgery and not necessarily clogging up your clinic with patients who are getting surveillance. And if you're a medical oncologist, you have no need to see a patient who has stage 1 lung cancer because you're not giving chemotherapy and not necessarily trying to adopt them into your oncology practice because that's where your RVUs are generated from. So who's minding the shop? To answer this, we went back to our serum Medicare databases, that cohort of 18,000 patients, and we pulled all of their claims data for outpatient clinic visits as well as for imaging claims. So we analyzed almost 2 million outpatient clinic visits and 200,000 imaging tests. And we matched each of those clinic visits as well as their imaging studies with the American Medical Association UPINs for each provider to come up with their specialty, at least their self-reported specialty, to figure out who's doing what and where. And what we found was pretty interesting. 98% of patients were following up. And it makes sense because these are patients who just had surgery. So they've already sort of proven the fact that they do have linkage to care and they're otherwise fairly aggressive in pursuing their care. So it's not as if patients are simply lost to follow-up. They are following up. But who are they following up with? Primary care. By and large, primary care. So 80% only goes down to about 70% by 5 years out. So they are actually maintaining their linkage to care. What about all the specialty providers? Well, they're all the way down here. And in fact, again, these are all patients who've had surgery. And even at the very earliest time frame of that 7 to 12 month period, only about 40% of patients are actually seeing their surgeon, which is a little bit disturbing as well. And then all the specialists just sort of trickle down to only about 20% of their clinic visits after that. And when they're seeing each other, sorry, I sort of messed up the font here, so it's hard to read, but when they're seeing these different specialists, what type of studies are being ordered? The surgeons, the pulmonologists, and the primary care providers are doing a poor job because they're all ordering chest x-rays, which is, again, problematic, and certainly something that I wasn't expecting to see from the surgical population or the pulmonologists necessarily. But the radiation oncologists and the oncologists are doing better, but even still, about 50% of the imaging that they're ordering is CT scan compared to chest x-ray or PET scanning, for instance. So we actually, on the heels of this, did a survey to see what's happening in other parts of the world. So we kind of thought we had a little bit of a sense of what was going on here in the U.S., but we wanted to see how does that compare to our surgeon counterparts in Europe and in Asia. And to do that, we partnered. So we had this survey that went out to members of the Society of Thoracic Surgeons, to the European Society of Thoracic Surgeons, and to the Japanese Association of Chest Surgeons. And we queried them to find out amongst asymptomatic patients who've had surgical resection, what type of testing do you do? And what we found is, by and large, everyone said you should get a history and physical, so you should see your patient. Fairly consistent among those three groups. But then we start to get some serious inconsistencies. And so you can see that the Japanese surgeons were much more likely to rely on chest x-rays and non-contrast CT scans than, say, the surgeons in the U.S. or the surgeons within the European Society. And then you have even more heterogeneity when it comes to using the use of low-dose CT. And then these here in red are the ones that there's really no evidence for. Again, these are asymptomatic patients, so no need to go and pursue PET scans, bone scans, MRIs, brain CTs, or bronchoscopy, but yet you can still see that there's a not insignificant number of surgeons in these various societies who do advocate for their use in asymptomatic patients. So these guidelines really tell us this, that most non-small cell lung cancer patients do receive clinical follow-up, so there is an opportunity to intervene upon them, and that's mostly dominated by primary care. Well, if you're a primary care surgeon, probably the last thing you want is for someone else to dump yet another thing on your plate that you are expected to do as part of routine care for your patients. Less than half of surgically resected patients are actually seen by their surgeons beyond that initial postoperative period. And less than half of the surveillance that's actually being done is in accordance with the NCCN guidelines, at least. So my main question here is more surveillance better? And can we link surveillance to actual improvements in outcome? Because doing more surveillance and more care, if you will, is not necessarily a good thing. There are some potentials anyway for some unintended negative consequences. You're going to be increasing patient anxiety, costs and resources of within a healthcare system. There's morbidity associated with doing invasive testing to follow up on some of the findings for surveillance. And of course, we're always trying to counterbalance the benefit of early detection and survival. But whether or not any of these interventions truly translates into survival is still up to debate. This is a nice meta-analysis, but it just sort of highlights the fact that the data that we have are rather sparse. 62 papers were actually reviewed, but only 9 were included in the actual meta-analysis, and about 1,700 patients. And what they found here, because they also had small cell and non-small, so that's a big problem as well. But in just looking at the non-small cell, the force plot in the upper portion of the chart here, you can see that the authors found a trend favoring more intense surveillance being associated with improved survival, but this did not reach statistical significance. And then if you specifically drill down to those who are asymptomatic and try to figure out what their survival looks like, we did finally get some sort of signal here that more intense surveillance was associated with improved survival with a reduced hazard ratio of 0.61. So maybe there is some benefit there. This study, however, which again was nicely done by Travis Crabtree and his partners at WashU, was a retrospective study, but it was nice in that they did try to do some propensity matching. So it's retrospective. Patients received chest X-ray versus CT scan solely based on provider preference. So really there's a huge potential for bias here, but they really found no difference in their unmatched or in their propensity matched cohort in terms of overall survival of the two groups. We went back to our SEER Medicare database since we already had all this data to look at, and tried to see, could we figure out, was there a difference in terms of survival based upon the data that we have. So again, looking just at that initial interval and trying to extrapolate downstream to see what their survival looks like is fraught with problems, if you will, from a methodologic standpoint. But we did try to do that analysis, and what we found was a little bit of signal as well, that at least for stage 1 patients, it did appear that having that initial CT scan in that first surveillance period was associated with a reduction in mortality, but not so for the patients who had stage 2 disease. Interestingly, simply going in and being linked to care and having a clinic visit showed no difference in terms of whether or not you had improved survival. So one of the problems that I think, as I mentioned earlier, was with regards to the heterogeneity of data and lumping recurrences in second primary lung cancers together. But I also think that there is a significant difference when you're talking about local regional recurrence versus distant recurrence, and whether or not you've got polymetastatic or oligometastatic disease. And even those second primary tumors, I think, again, those are really the guys that we have the potential to truly impact in a meaningful way. This study here I thought was a good study, and it just sort of underscores just a couple of studies underscoring the benefits of doing surveillance for the purposes of those patients who do receive surveillance. There's patients with stage 1A through 3B, 768 recurrences, so quite a bit, but they stratified folks in terms of polymetastatic or oligometastatic recurrences, most patients having polymetastatic disease. But nonetheless, of the oligometastatic, 2/3 of them were actually eligible for definitive treatment, and when they got that definitive treatment, they had a 5-year survival of 32%. Well, that's way better than any sort of second-line chemotherapy agent that we have out there, so there's a huge benefit if we can identify patients and get them the appropriate care. Another meta-analysis showed essentially the same thing. Small number of studies included only 9, but again, 5-year survival of 46% associated with metachronous second primary lung cancers who are actually eligible for treatment. And I put this up here because this is an opportunity, I think, that was capitalized through the National Cancer Database and the Commission on Cancer through the American College of Surgeons, where it was a special project. This was done by Benj Kosover and Caprice Greenberg, where they actually had the paid abstractors go back and find out those missing bits of information that are critical, like why did somebody get a study, and what did the subsequent studies show for a huge cohort of lung cancer and colorectal cancer patients. The problem I have with the study on the left, which is the lung cancer study, is that basically it did the same thing. It looked at what was happening very early on and stratified patients in terms of their first imaging having been obtained at 3 months, 6 months versus 1 year, and then just fast forward, went down to look downstream what was happening to them. Likewise, for colorectal cancer patients, they stratified them in terms of high versus low intensity surveillance. Neither study showed any benefit associated with surveillance, or no difference, I should say, between the 2 or 3 surveillance intensities. But I still think that it was a nice opportunity that was capitalized on, but not fully exploited. I think there was some more benefit that could have been gleaned from there. So the current data has some strengths to it in that we do have several large administrative data sets that have been analyzed that seem to show there being some signal present in terms of linking positive outcomes with more intense surveillance. But there's still a lot of weaknesses. When you use those administrative databases, you're really hindered by or limited to looking at very crude outcomes like survival. You can look at some secondary interventions, but you really have no ability to get much more granular detail that are needed in order to truly try to dictate someone's care. So we don't have those intermediary outcomes. Most of these data that I'm showing you are small single institution series. And particularly with SEER Medicare, of course, we like to use it a lot in health services research, but you have a very poor representation of what's going on in the entire population. You tend to lose your ability to say very much about young people, and specifically about women, and we know that that's a big problem because the 2 biggest demographics that are getting lung cancer at increasing rates compared to the rest of the population are women and younger people who have very limited smoking exposure. So what do we do with this lack of clarity? Why don't we have a prospective randomized trial? Well, there are issues in doing that, of course. There's a huge potential for cross-contamination bias between your exposure arms. There's a lack of provider equipoise, which I'll speak of in a moment, and there's significant provider bias and patient biases, all that have to be factored in whenever you're talking about doing something like this. So this was 2 surveys that I'm showing here. One was done in 1995, and then we repeated, this was Keith Nonheim again at WashU, repeated it with Keith Nonheim and myself this time in 2016, where again we queried surgeons from the Society of Thoracic Surgeons to see what their thoughts were in terms of biases surrounding seeking surveillance for surgically resected patients. And so in 1995, only 44% of surgeon respondents said that they felt that there was a survival benefit to doing surveillance on patients with stage 1 disease, which is like really nihilistic. And these are the people that are supposed to be the champions for doing the most aggressive interventions that we have with regards to lung cancer patients. So that was a bit problematic. When we repeated it in 2016, we have some positive results there where the sentiment went from 44% up to 66%, which is great. But also there was really a minimal change in the belief that the current literature actually supported that belief. So why it is that they thought that it was more beneficial is unclear, because certainly it wasn't because of some huge changes in the literature that supported that change. So my problem here is that I feel like we kind of have this one-size-fits-all mentality where we're really struggling trying to fit a square peg into a round hole and missing an opportunity to come up with a more tailored way of looking at surveillance for individual patients. This is a really neat study here. This is Nate Malberg, who was one of our trainees at University of Washington, along with Mark Ferguson. And what they did was, it was a theoretical paper, but they basically said, hey, for any patient who's having a surgical resection for lung cancer, why don't we do some risk assessment, figure out what their risk is individually, come up with the pooled data for patients meeting that particular profile, and plot out their curve for incidence of recurrence, look at where the peaks are, and marry that with the intensity of your imaging surveillance to come up with a much more tailored approach. So at least theoretically, that makes a lot of sense. They didn't do it, but they laid out the groundwork for doing so, or at least the rationale. And it really can be done. It was a nice study basically showing that we have a lot of low-hanging fruit that we can already use to try to risk stratify people in terms of their risk of recurrence, just based upon smoking status, angiolymphatic invasion, just some of the tried and true, if you will, markers for risk for recurrence. And if you stratify patients out, you can see really nice separation of your survival curves based upon just those sort of very basic clinical parameters. This is the landscape of the molecular testing for lung cancer. And you can see here that if we were able to take some of these crude metrics that we have and overlay on top of that what we know about the changing landscape of the molecular profiling of lung cancer, we can potentially come up with some really sophisticated risk stratification schema. If you just look at some of the low-lying fruit when it comes to molecular mutations, huge differences in your survival based on your EGFR mutation status, huge variations based upon your KRAS mutation status, and huge differences in survival, progression-free, and overall survival based on ALK. So those are just three, right, of all the molecular markers that we have out there. And most patients, at least in academic centers, are going to be getting those molecular testing done. But what are we doing with them? Well, we're trying to figure out who's going to benefit from targeted therapy, which is important, of course, but we're not really harnessing the full potential of that rich data source. We can also talk about circulating tumor cells. At Stanford, we have a number of investigators that are doing a lot of work with regards to circulating tumor cell DNA, but it really hasn't been used. It's mostly being used in the setting of detecting disease, and not so much in terms of detecting recurrences, but you can at least envision the potential there that throwing this in the mix too, we could have really powerful means by which to figure out who it is that we should be doing the most intense surveillance for and how best to do it. So we've evolved a little bit. At least the NCCN has started to evolve a little bit. But we've got, like I said, our crude metrics of what's going on in terms of trying to predict who's going to benefit the best. And then this is the most recent iteration of the NCCN guidelines. And I put these up here from August 2020, but really they changed in 2017. And finally, for the first time, we got a whole lot more words going on rather than just take everybody and scan them every 6 to 12 months. And what happened here in 2017 is that the NCCN said, hey, let's start to stratify people based upon their pathologic type as well as the treatment that they've received in terms of more intense versus less intense surveillance. No data upon which this was actually put out there, but at least they're thinking about it and trying to figure out ways in which that we can be more thoughtful with regards to how it is that we spend our healthcare dollars and utilize our healthcare resources. We actually did this study. This is a small retrospective study that we just did at Stanford for one of our fellows, where we tried to tease apart, actually, does that really make sense that stage 1 patients should actually get surveillance later than stage 2 patients, or less frequently than stage 2 patients? And it does appear that there would be some rationale for that. So it was only 162 patients, but we had nearly 6 years of follow-up, had a fair amount of recurrences, almost 30%, at a mean of 29.5 months. And what we found in the top left is the peak incidence for patients with stage 1 disease was later at 25 to 36 months compared to the peak incidence for recurrences for our stage 2 patients, which is at 19 to 24 months. So again, trying to figure out where you want to cluster your imaging to be done, you can readily figure that out if you just look at what the stage of presentation is and the treatment that a patient has received. At least that's the rationale that seems to be supported. So this study was a highly anticipated study, and it's still anticipated because it hasn't been published in manuscript form. So this is only based on an abstract presentation at ESMO in 2017. But this is a French trial where this was our holy grail. This is the NLST equivalent for surveillance, where we actually had patients who were randomized, 119 centers, started in 2005 to accrue 1,700 patients, all within France. And patients are randomized to either less versus more intense, so less being just an exam and chest x-ray versus exam, chest x-ray, and CT plus minus bronchoscopy. And the primary endpoint was overall survival, and the secondary endpoints were cost effectiveness, disease-free survival, post-recurrent survival, and quality of life. So they did not report in their abstract on all of these outcomes, but they did report their survival. And what they had was they had all comers, so stages 1 through 3A pretty much, T4 all the way up to N2, so pretty heterogeneous group of patients. They had pretty nice distribution in terms of randomization for chest x-ray versus CT scan, and they had really long follow-up, 8.7 years median follow-up. The overall survival for the chest X-ray group was 8.2 years, and the overall survival was 10.3 years, although the median was not reached yet. So you would think that maybe there's some signal there in terms of more intense surveillance being associated with longer survival, but that's not what was borne out in the data that they presented. We have equivalent 3-year and 8-year disease-free survival for both groups. And this is just to point out again that very heterogeneous nature of the study population. This is what their survival curves look like, and their conclusions basically was that yes, if you do CT scanning, you're going to detect more recurrences and second primary lung cancers. Again, they put them both together. They did not split them up. But really, there's no translation into improved survival benefit. But what they did do is do some other exploratory analyses where they said, okay, well, let's look at patients with stage 3 disease and see, did you recur within 24 months or not? And they concluded that really there's no benefit to doing surveillance within the first 24 months for these patients. So don't even bother doing any surveillance on a stage 3 patient. So it's really hard. That's a bitter pill to swallow, to just say, yeah, we're going to see, are you alive at 2 years? And if so, then we'll go ahead and start doing surveillance imaging for you. That's a tough one, but maybe that's very French. I don't know. But that was what their conclusion was. And you can imagine that's kind of hard. So if you've got a patient coming to see you here in clinic and you're like, hey, fantastic, we did a great job, we did a slam dunk, we got your tumor out, et cetera. Come back in 2 years. We're not going to do anything until then. And then if you're alive, we'll go ahead and get you a scan. So in my mind, we have a bit of a standoff where we have opposing viewpoints between the NCCN guidelines, the latest iteration, and the findings from the French trial. Because as I said, it was a highly anticipated trial with a lot of people planning to change their practice patterns based upon the results of that. Well, you have the NCCN that says, hey, if you've got more advanced disease, you should get more frequent imaging. And then you've got the French trial that says if you have more advanced stage disease, you should have less imaging, because that's not really going to impact your survival overall. So why persist with all of this? I mean, I basically showed you a whole bunch of data that's all over the map. Some says yes, some says no, some says more, some says less. I still think that there's a significant amount of murkiness in this area, that there's still an opportunity to try to clarify things a bit further. And in doing so, clarify some of the decision conflict, because at the end of the day, you want to be able to arm providers who are seeing people on the front lines to be able to confidently say to their patients, this is what we're going to do now. I do still think that there's a potential to reduce some of the unnecessary testing. We may be over surveying people, and in doing so, maybe even potentially causing some harm. There's also the potential to reduce costs and maximize allocation of resources, and also to prepare for emerging trends, because as I mentioned, we've got lung cancer on the rise still amongst women, and particularly young women who are never smokers or have very little smoking exposure. So the stage migration as well as the demographic profile is changing. So this is the VA Merit Award that I have. It's called ISALT, and these are the goals of the study. The first ones are pretty straightforward, which is basically kind of recapitulating what's already been done, but this is using VA data, so a totally different data source. And you can say a whole lot of things about the VA, but one of the things that is really, really good about the VA are the rich amount of data that lives there, and you just got to have the wherewithal to dig in and hunker down and pull it out. It's like a big tumor. So, but it's there and it's beneficial. So, but at the end, the third aim of the study actually, just after trying to figure out what's best within the VA and how should we be doing this better, is to look at the association between guideline concordance and clinical outcomes, but then to try to model prospectively what is the optimal strategy, and try to get some of those granular details that are missing from the other large administrative databases that we have. So to do that, this is the tumor. This is the repository of all VA data. We've got VA raw oncology data, which is very raw, but nonetheless has all of our cancer covariates in it. And we use that to come up with our cohort as defined for entry into the study. And then we have the CDW, which is the Central Data Warehouse, which has all of our generic clinical covariates and demographics for patients, including smoking variables, et cetera. And then we have this treasure trove of radiology reports and progress notes, all of which are digital data points in the CDW. And they're just sitting there as this big amorphous mass, if you will. And so if you have the means by which to get in there and pull out that data, then you can have some really interesting analyses. So that's what we're trying to do. Specifically, we're looking at those radiology reports. So every radiology report is dictated and lives in CDW. The problem is that there's not a lot of consistency. In fact, there's very little consistency. You would think that pathology reports, you've got your pathology abstract and radiology reports. No, it is absolutely all over the map, from a one-liner about a chest x-ray to like an entire paragraph. But nonetheless, we want to figure out the missing pieces. So what are the indications for a given study? Why are you doing it? Was it for surveillance? Was it for symptoms? Was it looking for something else? And what did the radiologist point out? And did the radiologist recommend specific follow-up? And did the patient receive it? So that's just the radiology piece. Then there's a progress note, so we can also get additional information from it. But how do we get that information out of it? Well, there's manual chart abstraction, which those special projects through the NCDB utilize. Hugely labor intensive, hugely. And you can appreciate that if I were going to try to sit down and analyze the charts of 17,000 patients, I might need more than one VA Merit Award and one chart abstractor to do that, and more than one lifetime, because it's incredibly labor intensive to do it right. So you can pull in natural language processing and some machine learning to try to figure out how it is that we can tackle the beast of a big data monster of free text. But there are huge problems associated with that. So my colleagues and I at University of Washington actually use this LUCENE tool that I'm going to show you to look at screening CT scans, to just look at their ability to define and characterize lung nodules. And that was a big problem, because you go from having a radiologist report that says 2 millimeters typed out as TWO, millimeters spelled out, versus millimeters as mm, versus 2 mm with no space, 2.0 mm. I mean, it's all over the map just to describe this 2 millimeter nodule, which of course we don't really care about a 2 millimeter nodule. But so the NLP and machine learning are not necessarily the panacea. They're not the silver bullet that's just going to make this all get better. So in my grant, we're doing a hybrid. So we call it a semi-automated chart abstraction. So we're trying to figure out what are the limits of the use of computers to distill the data down to a reasonable size, so that we can then have the manual abstraction take place to get those details that we need. And this is what this looks like. This is the LUCENE tool. All VA data lives within this virtual server called Vinci. And so this LUCENE tool lives within Vinci, and you get all your CDW data as this huge data dump, and then you pull it into this tool, all being done in this virtual environment. And this is just showing gibberish, but the point is that each one of these little folders, oops, sorry, oh well, screwed that up. Each one of these little folders here is an individual patient. So this individual patient that got these 3 studies, and it's going to highlight text based upon what we had in our search fields. And then what the abstractor is going to see then, as she clicks on a given patient, is this, which is the highlighted text. It's actually is quite dense. It doesn't normally look this dense. But then she has her abstraction sheet down here, where she's able to pull these drop-down menus and quickly code that individual patient, as opposed to sort of the tried and true method of going into the patient chart and clicking a radiology exam and reading the whole radiology report just to figure out what it is that you need to glean from it. So we're sort of at the midway point with this. We did some quality checks, if you will. First, we did a whole lot of abstraction training to get to the point where we're about 95% concordance between our 2 abstractors. We have a training cohort of about 3,400 imaging reports from 378 patients, And this is the test performance for just figuring out, is this the right study that we need to include within our, the right image type to include within our study. We have some problems here. So CT abdomen pelvis, for some reason, is not performing well with the search queries that we have, and neither is MRI of the body. And then the other thing that I'll point out here is the fact that for imaging indication, if all we're trying to do is figure out, was this study done for surveillance, it's not very good. And I think that that's telling because, as I mentioned, we're trying to figure out the limits of what the computer can do and marry that to, or figuring out where it is that we then need to start abstracting. And so when I look at this, I say, okay, we're not going to be able to get that information fully from just a computerized search. We really need to have the abstractor sit down there and figure out how we can get this to a more manageable size, but have the abstractor be the one that's actually going to be categorizing imaging studies as for surveillance or otherwise. And then lastly, I'll talk about sort of that last little reason for doing surveillance, and that's for palliation of symptoms and quality of life. Because I think lung cancer patients get a bit of a bad rap. There's still a fair amount of nihilism there that I don't even know what we're doing this surveillance. I mean, you're a smoker, you got lung cancer, that kind of sucks for you. But isn't it cool that you're alive and you should just go on like Gus and do your thing? But patients do have a lot of stigma and blame and shame that they all carry with them as they come in to see you for each of these visits. And these are real quotes from some of my patients that we did in this other study. But you can't just say, hey, come in every 2 months for a CT scan and expect that to go over really well necessarily. And you can't sit up there in Silicon Valley and say, hey, we're going to see if you stay alive for 2 years and then get that CT scan after that, because that's not going to go over very well either. So there's got to be a way in which we can try to minimize some of these harms and be sensitive to the patient and their issues that they're experiencing as well. And the case for palliative care is a strong one. I thought this was a really neat study because this was within the VA as well. And basically what they said is that palliative care matters. If you do palliative care, people can actually live longer, which seems somewhat counterintuitive, right? But you got to do it right. If you institute palliative care too early, that's associated with a decreased survival, which I don't think that's the case. It's not as if you're hastening their death, but you probably were appreciating the severity of their illness at the time that you otherwise operated on them or what have you. But if you hit that sweet spot of 31 to 365 days, then you actually do have a huge survival benefit associated with having timely receipt of palliative care. I think this is the last slide here, which basically I like to show up every once in a while. I keep doing this little Google search to update it, but you can see that it isn't a one-size-fits-all, and not at all to disparage any of the researchers out there who do breast cancer research or people who take care of breast cancer patients, but there's a big difference. 326 million hits versus 7 million hits for breast cancer survivors versus lung cancer survivors. And they're not the same populations. And although there's lots of commonalities, it's a very different thing to say, let's go ahead and extrapolate everything that we know from the breast cancer literature and apply that to the lung cancer patients, or vice versa, or colorectal, or head and neck, or whatever. These are special populations, and they really deserve a discerning eye. So, in summary, these are what I think are the barriers to progress in post-treatment care for our lung cancer patients. We still don't have a high level of data upon which to make our declarations and guidelines. There is still a fair amount of provider bias, even amongst those who are otherwise charged with being the champions of these lung cancer survivors. There's still patient biases as well that need to be factored in terms of anything that we propose. Many patients still don't really have a great medical home that is able to coordinate their complex specialty care. And then, of course, there's really no reimbursement incentive at all. And so until there's any sort of reimbursement associated with providing good survivorship care, we're really going to be kind of behind the ball to incentivize people to do this work. Thank you.
So, Dr. Backhus, thank you so much for that great presentation. I do think there's this huge, just like the valley of death between, I don't mean that sort of I'm trying to get my Silicon Valley analogies with my cancer analogies, but for cancer survivor patients, between who takes care of them? I thought that was really poignant about, nobody gets the RVUs for doing that important work. And if you're a patient, that's the most important time for you. You've just recovered. You've just been given a second lease on life. And so that's a really interesting observation and how to think about that group. Your work is fabulous, really fun to see. And particularly, thank you so much for coming up here. We have a minute for questions. If there's one burning question from the audience, not surprised from our wise lung cancer surgeon.
And we also may have some questions from our rest of our department who's up in the ether. Thank you, Dr. Backhus. This was a wonderful overview about surveillance, and I'm a little surprised about the surgery data of surgeons, thoracic surgeons, presumably not. And you had the SCS data too, SCS survey, not really providing standard of care, evidence-based surveillance. What are your thoughts with the sort of the CARES Act and the deregulation and reimbursement liberation for telemedicine? Do you think that will have an effect on adherence to surveillance imaging, especially, as surgeons, we will take care of folks who come from large geographic areas and disparities. And then there's, I imagine, some of the reimbursement issues is fear of taking up clinic time for the ability to see new patients. Do you think there'll be sort of a shift towards proper compliance?
Thank you for your question. I mean, I hope so. I think that the momentum would be in the positive direction for all the reasons that you mentioned, that we finally have good or better reimbursement models for providing telemedicine to patients. And hopefully that's going to allow patients to have better access to care because they don't have to come in. They still have to go get a scan, right? So that's a little bit of an albatross there for some. But, they can get their scan locally, right, and not have to still come all the way into the clinic. So I do think that there's a potential opportunity for things to get better for sure. And their their providers who kind of parse out their clinics. Like everybody has their own style. How do they do their telemedicine? Do I have a half day that's all telemedicine that I just do from my office, and therefore I don't feel that it detracts from my ability to see those new pre-op patients and so on. So I think that there's some potential benefit big time.
Great, thank you.
Well, thank you so much. Today's our day for plaques. We also don't want you to forget UC Davis. We have our little sort of DNA in the entryway that you probably noticed.
Yes, I did.
Sort of slightly in the background there.
Beautiful.
So thank you so much for coming. And I don't have to worry about telling you that it's safe to go through the airport screeners.
No
It's not a weapon.
agents.
Exactly. No TSA agents.
That's right.
Anyway.
Thank you so much.
Absolutely.